Hello, everyone, and welcome to our first module on cranial nerves. So the cranial nerves are 12 nerves who have their nerve roots in either the brainstem or higher up in the central nervous system. So this is different from other nerves that have nerve roots in the spinal cord. They can be sensory or motor or both, and we're going to go through all 12 cranial nerves in this video and the second video on cranial nerves. And things you want to keep an eye on as you're learning about the cranial nerves are, first of all, whether they're sensory or motor or both. You also want to know something about their nerve pathways through the skull. And then probably the most important thing is to know what happens when you have a lesion involving one of the cranial nerves. You need to know what clinical features that will cause. So let's start by talking about the olfactory nerve, which is cranial nerve number 1. This is a purely sensory cranial nerve, and it's responsible for the sense of smell. The way this nerve works is axons which detect smell travel through the cribriform plate of the ethmoid bone, and then they enter the skull and they form a structure called the olfactory bulb. So to understand this, let's look at this drawing on the screen. So you have nerve endings in the nasal cavity that are responsible for our sense of smell. They travel through the cribriform plate in this bone right here, which is part of the ethmoid bone, and then they form a structure called the olfactory bulb, which is picking up all the sensory information about smell. And then the olfactory bulb will send signals to the olfactory cortex, which is found in the temporal lobe. And so I've summarized these points here: axons of the olfactory nerve synapse in the olfactory bulb, and that sends signals to the olfactory cortex in the temporal lobe. And it's because of the fact that the olfactory nerve sends signals to the temporal lobe that some patients who have temporal lobe seizures can develop an abnormal sense of smell as part of their seizure syndrome. You also should be aware that cranial nerve number 1, the olfactory nerve, is sort of famous in that it's the only sensory cranial nerve that does not send input to the thalamus. All the other cranial nerves that carry out sensory roles send their signals to the thalamus, and from there it's relayed to the cortex. That is not true for the olfactory nerve. If you get a lesion to this nerve, the clinical features are anosmia or loss of the sense of smell. This can happen from trauma, especially skull fractures. The ethmoid bone is a very small, thin bone. It's easy for it to be fractured in a trauma. And rarely you can have lesions of the olfactory nerve from infections or from tumors or other things. Okay, moving on. Next, let's talk about the optic nerve, which is cranial nerve number 2. This is another purely sensory cranial nerve, and it's responsible for our sense of sight. The pathway this nerve travels is from the retina, where light waves are picked up and detected, through the optic canal of the sphenoid bone, and from there signals are sent into the cortex and the brain. The optic nerve is sort of famous for the fact that it's not really a peripheral nerve. It's actually an extension of brain tissue. It's an extension of the diencephalon, which is the forebrain. This is part of the brain that's found at the upper end of the brainstem. Other structures that are part of this region are the thalamus and hypothalamus. And so really, the optic nerve is just an extension of this part of the central nervous system. In fact, it's surrounded by meninges as if it's part of our brain itself. Another thing to know about cranial nerve number 2 is it doesn't emerge from the brainstem. So most of the cranial nerves have nuclei in the brainstem. The exceptions, the major exceptions, are cranial nerve 1 and 2. They're found above the brainstem. And if you get a lesion of the optic nerve, this will lead to vision loss. And I talk about lesions of the optic nerve in more detail in videos in the ophthalmology section. Okay, our next cranial nerve is the oculomotor nerve, cranial nerve number 3. And it's called oculomotor because it's purely a motor nerve that's responsible for eye movement. It innervates 5 muscles related to the eye. They're all listed here: the superior rectus, which moves the eye upward; medial rectus, which moves it medially; the inferior rectus, which moves the eye down; the inferior oblique, which does superior rotation of the eyeball; and finally the levator palpebrae, which elevates the eyelid. In addition to its major motor function, it also has an autonomic function related to the parasympathetic nervous system. There are fibers that travel with the oculomotor nerve that innervate the sphincter pupillae. This is a muscle that causes pupillary constriction as part of the parasympathetic nervous system. Also, the ciliary muscle is an autonomic muscle innervated by the oculomotor nerve. It's responsible for accommodation, which is changing the shape of the lens to focus on near objects. And so if you have a palsy or a lesion of the oculomotor nerve, what you get is the eye turning downward, outward, the pupil being dilated, and ptosis, which is drooping of the eyelid. That's shown here in this picture. So to understand why you get this finding, first of all, you lose innervation of the superior rectus, which moves the eyeball up. So that's going to cause the eyeball to move downward. That's what you see here. It's not drawn very well, but this eye is rotated downward. You also lose the medial rectus, which moves the eyeball medially towards the nose. That means it's going to end up moving laterally because of unopposed action of lateral muscles. So that's what moves the eye outward. So now we have the eye moving down and out. Then we lose these autonomic fibers that cause pupillary constriction. So as a result, you get unopposed pupillary dilation, and that's what leads to the dilated pupil. And then finally, you lose innervation of the levat or palpebrae. That helps to elevate the eyelid, and that's why the eyelid droops. So make sure you can recognize a third nerve palsy. It comes up in lots and lots of clinical syndromes. Here's a drawing that I go through in detail in videos in the ophthalmology section. It shows the different muscles that control eye movement. And all the muscles here with the 3 next to them, like the superior rectus and the medial rectus, those are all innervated by cranial nerve 3. And the mnemonic a lot of people use to remember which cranial nerves innervate which muscles of eye movement is LR6SO4AO3. This means that the lateral rectus is innervated by cranial nerve 6, which we'll talk about later. The superior oblique is innervated by cranial nerve 4, which we'll also talk about in just a second. And then all other muscles, that's the AO, are innervated by cranial nerve 3. The nucleus of cranial nerve 3 is found in the midbrain, and from there, the fibers that are traveling to the eye muscles pass very close to the posterior communicating artery. And because of this, aneurysms or dilations of the posterior communicating artery commonly lead to cranial nerve 3 compression and an oculomotor nerve palsy, and I talk about this in other videos. The way that the nerve gets to the muscles of the eye and through the skull bones is by passing through an opening called the superior orbital fissure. If you look at this drawing at the base of the skull in the slide here, this is the superior orbital fissure here. It's this opening located in this region here. And all of the nerves that are going to innervate muscles of eye movement pass through this opening of the skull. So cranial nerve 3 passes through here. So does cranial nerve 4. So does cranial nerve 6. And so does one of the branches of cranial nerve 5 that's responsible for lacrimation related to the eye. Okay, our next cranial nerve is the trochlear nerve, also known as cranial nerve number 4. It's a purely motor cranial nerve, and it's responsible for eye movement of one muscle that we already talked about. That's the superior oblique. It's the smallest cranial nerve, and the reason it's so small is because all it does is innervate this one muscle, the superior oblique. This muscle is responsible for turning the eye downward and for intorsion, which is rotating the top of the eye outward. So if you have a lesion of this cranial nerve, the symptoms will be an eye that looks like what's shown here on the slide. This eye here has a trochlear nerve palsy. So let's talk about what's going on. First of all, you've lost the ability to turn the eye down because the superior oblique is not working. So that's going to move the eye upward like you see here. And then the superior oblique muscle normally rotates the eye like this. It turns the top of the eye outward. So what you're going to get when you lose the superior oblique is unopposed action in the opposite direction. That's going to turn the eye this way. So as a result, you've got the eye that's sort of moved in towards the center and up towards the top right corner. That's what a trochlear nerve palsy looks like. This is going to cause problems when you need to look up or down. This is called a vertical diplopia. Anytime you have blurry vision when you're trying to look up or down, that's a vertical diplopia, different from a horizontal diplopia when you have trouble looking left or right. As I already said, the eye is going to be tilted up and rotated inward with the pupil towards the nose. That's what's depicted in this image here. And the clinical features this will lead to is that the patient will complain, if they have a trochlear nerve palsy, of difficulty looking down and in. This is going to cause vision problems when they're trying to do things like going downstairs or reading. These are things where you need that superior oblique muscle to turn the eye downward and inward. Another thing patients classically complain of when they have a trochlear nerve lesion is that they tilt their head away from the affected side to compensate. So once again, if you look at this image on the slide, the affected eye is sort of tilted this way. And so if the person tilts their whole head in this direction, sort of downward like this, it's going to even out this eye on the side that's not normal. And that can make the vision a little bit more clear, tilting the head away from the affected side to compensate. So to make sense of this, imagine we have a right eye like this, and it's got a trochlear nerve palsy, so the pupil is pointed up like this in this direction. Over here on the other side, we've got the left eye, pupil's normal right in the middle. Well, if the person tilts their head away from the side of the lesion, what's going to happen is this right eye is going to straighten out, and the pupil will be sort of closer to the midline, just a little bit medially rotated. The left eye has normal motor control, so it can adjust to the head being tilted. So as a result, by tilting the head, you sort of fix the abnormal eye, and the other eye can adjust, and this evens out the vision. The trochlear nerve has its nucleus in the midbrain, just like the oculomotor nerve. One unusual thing about this nerve is that it crosses or decussates in the midbrain. So if you have a lesion of the left trochlear nerve, this will give you a right eye defect. This is the only cranial nerve that crosses like this. All the others, if you have a lesion of the cranial nerve itself, you get a lesion on the same side of the body. That's not the case for the trochlear nerve. It passes out of the skull into the orbit where the eye is through the superior orbital fissure. Remember, that's this structure right here, and lots of cranial nerves that have to go to the eye exit the skull through this structure. Okay, moving on. Our next cranial nerve is cranial nerve number 5, also known as the trigeminal nerve. And the trigeminal nerve has both sensory and motor functions. Let's talk about the sensory functions first. So most sensation of the face and scalp comes through this nerve. So it innervates the face, the scalp, also the cornea of the eye, also the nose and the nasal and oral cavities, also the teeth. It also provides general sensation to the anterior two-thirds of the tongue, not taste. Taste is mediated by other cranial nerves that we'll talk about later. And importantly, this nerve is part of the corneal reflex, which we'll talk about in a second. If you lose function of this nerve, you will lose the corneal reflex. In terms of motor function, it's important for the muscles of mastication. So when you chew, that's being carried out through the trigeminal nerve. It also innervates the tensor tympani, which is a muscle that elevates the palate. And so a lesion of this nerve can cause problems with the palate not elevating normally. In terms of the location of the trigeminal nerve nuclei, there are 4 brainstem nuclei. Most of them are located in the upper pons. That's generally where you find the source of this nerve. And it's called the trigeminal nerve because it branches into 3 important divisions, which each do different things. I've summarized them in this table over here. The divisions are called V1, V2, and V3. The motor fibers are all part of V3. They exit the skull through the foramen ovale. Most of the sensory fibers go out through V2, which exits through the foramen rotundum. But then there are some fibers that go to the eye, the ones that innervate the cornea, and those go out through V1, and they go through the superior orbital fissure of the skull, just like all the other nerves that are going to the eye that we've already talked about. So when you have a palsy or a lesion of the trigeminal nerve, let's talk about the clinical features. So the most common thing is sensory loss. Patients with a trigeminal nerve palsy will complain of unilateral facial numbness. Sometimes they will also have other neurologic sensory symptoms like burning or tingling. In addition, they will lose the corneal reflex. So we'll talk about the corneal reflex later, but this is a reflex where you touch the cornea with a cotton swab and the patient will blink. The sensation to touching the cornea is via the V1 branch of the trigeminal nerve. The blink, on the other hand, is via cranial nerve 7, the facial nerve, which we'll talk about later. But so if you have a trigeminal nerve palsy, you don't have this sensory arm of the corneal reflex, and as a result, patients won't blink when you touch their cornea. And then by losing the muscles of mastication, patients will develop a weak jaw. Classically, the jaw will deviate towards the affected side. So the idea here is that the jaw is sort of kept in the midline by muscles on each side pushing it to the midline. So if you lose one side, then the jaw is going to deviate towards that affected side. This is basically unopposed action of the normal side, as I've listed right here. You will also lose the jaw jerk reflex in a trigeminal nerve palsy. So the way the jaw jerk reflex works is you tap the chin and the patient will jerk their jaw upwards. That will be lost if there is a cranial nerve 5 palsy. There's also a pain syndrome that can develop when there's a trigeminal nerve lesion, and that syndrome is called trigeminal neuralgia. This refers to severe stabbing unilateral facial pain in the distribution shown right here. This is the region of the face that has sensory information by the trigeminal nerve, mostly via V2 and V3 branches. This can happen when there's compression of the trigeminal nerve root in the brainstem by a mass. You can also see it if the trigeminal nerves are affected by multiple sclerosis. It's going to present with pain in this region that I've shown on the slide here. Also, patients can sometimes say the pain comes and goes with these zapping symptoms. This is called tic douloureux, a painful tic. It's called a tic because it's so intense that it makes the patient wince. So this collection of symptoms right here, called trigeminal neuralgia, is seen in some situations where the trigeminal nerve is irritated. It often responds to treatment with the anti-seizure med carbamazepine, and I talk about this in other videos. I've mentioned this a few times, but just to make this point very clear, let's talk about the corneal reflex. So the way this works is you touch the cornea with a cotton swab, and that touching of the cornea is sensed by the V1 division of cranial nerve 5. It's transmitted through the brain to cranial nerve 7 bilaterally, and cranial nerve 7 will cause both eyes to blink. This is the corneal reflex. So you need the trigeminal nerve, cranial nerve 5, to sense the touching of the cotton swab, and you need cranial nerve 7 to blink. So if this reflex is absent, it means one of these 2 cranial nerves has a problem. Okay, our next cranial nerve is cranial nerve 6, the abducens nerve. This is another cranial nerve that just innervates one muscle, and it's another muscle of eye movement, the lateral rectus. We talked about this earlier. This is the muscle that moves the eye laterally or away from the nose. So if you have a lesion or a palsy of this nerve, what you get is diplopia, which means blurry or double vision. The eye will be turned medially towards the nose, just like what's shown in this picture right here, and the patient won't be able to laterally move the affected eye. So if you ask this patient to try and look in this direction, the eye on the right, if there's an abducens nerve palsy, won't be able to do that. That's because the lateral rectus is not working. The nuclei for this nerve is found in the dorsal pons, which is the back of the pons. It exits the skull and enters the orbit through the same pathway that all the nerves going to the eye use. That's the superior orbital fissure. And one sort of quirky thing to know about this nerve is because of its pathway and because it's such a small nerve, it's highly vulnerable to raised intracranial pressure. The reasons for this are complex. Some of it has to do with the fact that it travels near skull bones. So if the pressure gets high, it can easily compress this nerve. But what you should know is patients who have problems where they have high intracranial pressure, either from a brain tumor or from pseudotumor cerebri, sometimes the first symptom they present with is a palsy of this cranial nerve. Okay, and then our last cranial nerve we'll talk about in this video is cranial nerve 7, also called the facial nerve. So the reason it's called the facial nerve is because it supplies motor innervation to the muscles of facial expression. So when you smile and you move your cheeks, that's the facial nerve. It also innervates the stapedius, which is a small muscle found in the middle ear. It's near the stapedius bone, and it's responsible for dampening large sounds. Why is this important? Because patients who have a facial nerve palsy often become intolerant to loud sounds, and that's because this stapedius muscle is not working. The facial nerve also has a sensory role. It provides taste sensation to the anterior 2/3 of the tongue. So when you use the tip of your tongue to taste something, that is being mediated by the facial nerve. And then it also has an important autonomic role. So it's responsible for lacrimation, the production of tears. It's also responsible for salivation and creating saliva in the mouth. The nuclei for this nerve is found in the pons, and it exits the skull via the internal auditory meatus. And it's called the auditory meatus because it's near the ear, and hopefully that makes sense to you. Since this does innervate one muscle of the middle ear, it makes sense that it exits the skull through a structure called the auditory meatus. There's a quirk about the facial nerve that has to do with the forehead muscles, so let's talk about that now. So the muscles of the forehead are innervated by the facial nerve, but the fibers that go to the forehead receive bilateral upper motor neuron input from the corticobulbar tract. So they receive upper motor neuron input from the right cortex and also the left cortex. The lower face, everything outside the forehead is different. Those nerve fibers of the facial nerve receive unilateral input from the corticobulbar tract. They only have a single upper motor neuron controlling their actions. This means that if you have upper motor neuron damage, the forehead, the upper face, will be intact. It has dual upper motor neuron supply. So you've got the right and the left cortex sending upper motor neurons to the facial nerve fibers that go to the forehead. If you lose one side, no problem, the other side can take over. So when there's an upper motor neuron lesion involving the facial nerve, only the lower face will be affected. And that's what you see in patients who have cortical strokes that take out like the right cortex, for example. The left side is still intact, and so the forehead is not going to droop. And so that's what's shown in this upper picture here. It's not very obvious, but this patient has droop in the lower face, but the forehead at the top on that side is intact. In contrast, if you have lower motor neuron damage, so for example, the facial nerve nucleus and the brainstem gets damaged, then you're going to lose innervation to the entire face, the forehead included. The upper and lower face will be affected. This is what you see with brainstem strokes. And so that's what's depicted here. This person has droop of the lower face and also droop of the forehead on the same side. This is a lower motor neuron lesion. This is an upper motor neuron lesion. Make sure you understand this. This comes up a lot in board questions and also clinically. And just to make this super clear, here's a picture from a textbook. So let's imagine we have lower motor neuron weakness. That's what's shown over here. So you have damage to the facial nerve itself, maybe the nuclei in the brainstem, or maybe the nerve fibers. That leads to droop that involves the entire face. Then over here on the right, we have an upper motor neuron lesion. We've lost the fibers of the upper motor neurons in the right cortex. That's no problem for the forehead because the left cortex is still going to control the forehead and keep it from drooping. So this person has a normal forehead, but their lower face is affected and it's drooping because the lower face only has unilateral upper motor neuron input. So now that we've got that out of the way, we can talk about the clinical features of a facial nerve palsy. First of all, you get facial droop. If the forehead is involved, it means there's a problem in the brainstem with the nuclei of the facial nerve or with the nerve fibers itself. If the forehead is spared, this means there's a problem in the cortex with the upper motor neuron corticobulbar tract fibers. Another clinical feature of a facial nerve palsy is hyperacusis. I already talked about this, but when you have paralysis of that small, tiny stapedius muscle, the patient cannot tolerate sounds. Patients will also complain of dry eyes and mouth because they lose lacrimation and salivation. You will lose the motor part of the corneal reflex, which we already talked about. And finally, you will lose taste sensation in the anterior 2/3 of the tongue. And then we'll finish with one slide about Bell's palsy. So Bell's palsy is a term that's used for an idiopathic mononeuropathy of cranial nerve 7. And what that basically means is an idiopathic cranial nerve 7 palsy or lesion. So this presents with symptoms like facial paralysis, lower motor neuron pattern because it involves the nerve itself, not the cortex and the higher nerve fibers. And then you can also see all the other features of cranial nerve 7 palsy we already talked about, like dry mouth and everything else. Usually, this is a self-limited syndrome. It resolves in a few weeks. It's called idiopathic because we don't know the cause, but it's believed to be related to reactivation of HSV1, herpes simplex virus 1. If patients are exposed, can become latent, and it may reactivate and it can lead to Bell's palsy, but we don't know this for sure. And besides this sort of idiopathic syndrome, you can also see an isolated cranial nerve 7 neuropathy in association with things like Lyme disease can cause this, certain tumors can cause this, strokes can cause this. Technically, these are not examples of Bell's palsy. It has to be idiopathic, but we often will say it's a Bell's palsy anytime someone has a cranial nerve 7 palsy. And when patients do have a Bell's palsy, whether it's idiopathic or from Lyme, we often treat it with corticosteroids that can improve the symptoms. And this can actually be very debilitating. I've treated a number of patients who've had this condition. It's really uncomfortable to not be able to control part of your face, not be able to close your eyes normally, and the loss of lacrimation and salivation can be very uncomfortable. And that concludes our first module on cranial nerves.